Thank you very much, Ken, for the introduction, and also to the University of British Columbia and Green College for this invitation. It's really an honor to be here. And it's been a great week so far for me to be thinking differently about what I do by having the chance to interact with Dr. Sullivan as well as many of the other people I've already met on campus. So I think I'm going to be walking away from this week really thinking differently about pain as well. And I should say that it has indeed been a busy week. It's only Tuesday, and I feel just as exhausted as I was when I completed my PhD under Ken's supervision here at UBC in the mid-90s. And indeed, he knows how to keep a student busy. So anyhow, thank you for joining us this evening. So I wanted to begin my presentation tonight by showing you this slide and introducing you to this baby, Elijah. Elijah, along with his twin brother Hayden, was born 3 months early, weighing only 1 pound, 8 ounces. And Elijah spent the first 4 months of his life in the neonatal intensive care unit, where he underwent many major and painful procedures and surgeries. We know from research studying children who are hospitalized in the neonatal intensive care unit, they undergo on average 16 painful procedures each day. And unfortunately, Elijah was no exception. In the first 6 weeks alone of his life, he underwent 858 painful medical procedures and surgery. However, even healthy children are not immune from painful experiences. Healthy children will undergo as many as 20 routine vaccinations by age 5. We also know that hospitalized children, not just in the neonatal intensive care unit, are at risk for significant procedure-related pain. This is data from a study that I've been part of, led by Dr. Bonnie Stevens at the Hospital for Sick Children, where she did a cross-Canada survey of the prevalence of painful procedures in hospitalized children. And she found that 80% of hospitalized children have had at least one painful procedure in a 24-hour period. And the average number of procedures was 6 per child. But what was most disturbing was when she conducted an audit of their medical charts to see how these procedures had been managed, she uncovered that 70% of these painful procedures had no form of documented pain management. And this is in spite of the fact that we have 20 to 30 years of research that have identified appropriate and effective evidence-based ways to manage pain, whether it be through pharmacological support, physical strategies, or psychological interventions. And kids don't just experience pain from procedures, they also experience chronic and recurrent pain. But many people think of chronic pain as an adult problem, but it affects children as well. We've conducted a series of studies and systematic reviews looking at the prevalence of chronic pain in Canadian children as well as children around the world. And we found across studies that children on average experience weekly or more frequent headaches, stomach aches, and back joint pain at the rate of about 20 to 25%, which means that 1 in 5 children and adolescents experiences chronic pain on a weekly basis or more. Now, not all children are significantly disabled by their pain. Many children have headaches and stomach aches and are able to go about their lives with a good degree of functioning. But we do know that 1 in 20 children is very significantly disabled by their pain, resulting in them staying home from school, missing out on critical events of childhood. This is a poem that a former patient of mine gave me when she was 15 years old, but she wrote it when she was 8. And it says, my tummy hurts, what can I do? I've called the doctor and I've seen a specialist, and there's nothing that we can do. So I have this tummy problem that we cannot stop. My tummy hurts, what can I do? So this poem summarizes the suffering that children with pain and their families experience. They're often told that the pain is just in their head. All their medical tests come back normal, and they say, you should be happy, you're healthy. But yet these individuals still have a significant problem that is poorly understood, and they often feel very alone. The history of pain in children is quite fascinating. It's hard to believe that as late as the 1970s and 80s, it was widely believed that babies didn't feel pain, especially preterm babies, that somehow they were too neurologically immature to feel pain. And so it was standard practice at the time when babies had to undergo major procedures and surgeries to withhold proper anesthesia and pain management and to simply administer paralytics so that they wouldn't move during surgery. There were concerns that it was just too risky. Well, this was not true. Babies do feel pain. And in the mid-80s, a mother went public with her story in a high-profile publication in the Washington Post. And in it, she sort of unveiled the widespread practice and belief that babies didn't feel pain. Her own son had undergone surgery, and she had specifically requested that he receive proper pain care and anesthesia, and he did not. After he died, she went back and reviewed his medical record. And of course, there was a public outcry. I mean, surgery without anesthesia, everybody knows that babies feel pain. So there was a public outcry. Out around the same time, a scientist named Sunny Anand published a powerful paper in which he contrasted babies who had undergone surgery with proper anesthesia and pain management and compared them to a group of babies who had not. So that was a standard practice at the time, not to receive proper anesthesia and pain management. And he actually showed that it was the babies who didn't receive proper pain care who were more likely to experience complications after their surgery, and they were even more likely to die. So it was a combination of a brave mother going forward with her story, uniting with powerful scientific evidence that sort of tipped the balance and served as a catalyst for the field of pain in children. And there were a variety of individuals working in fields like psychology and medicine and nursing in the mid-80s who all then began to contribute to the field of pain in children. And Ken Craig was one of those individuals who contributed some of the most profound early work on pain measurement in babies and our appreciation of the role of nonverbal behavior in pain. So why is pain important? Lots of people say, you know, pain can be over with in a moment. It's not important, you know, just move on, think about something else. But that's simply not true. We have lots of data now from animal and human studies that clearly shows that pain, early, poorly managed painful experiences can result in pain sensitization, causing individuals to feel more pain later in life. There's evidence coming out of Ruth Grunow's group here in Vancouver showing that, again, the frequency of painful procedures early in life is actually related to changes in the way that children's brains are developing. We also know that children with chronic pain become adults with chronic pain. 2/3 of children will go on to, or who have pain will go on to continue to experience some kind of pain problem as an adult. So if we want to better understand and deal with the problem of pain in adulthood, we can benefit from taking a developmental approach to understanding this complex health issue. We have incredible research capacity in Canada in the area of children's pain. This is a report from the State of Science and Technology in Canada published in 2012 that summarized, using some very sophisticated bibliometric and cluster analysis, areas of research specialization in Canada. And to our great surprise, children's pain research was identified as the #1 research specialty in Canada. The only other health-related area to make the list was traumatic brain injury at #10. So we're clearly showing incredible leadership, mentorship, training, and new discoveries and knowledge translation work as it relates to children's pain. That said, when you look at the quantity of published research on children's pain versus what's been published in adults, we're still a really small piece of the pie. This bibliometric analysis conducted by Jeff Mogul at McGill showed that only 5% of published papers over a near 30-year period were dedicated to children's pain. What makes studying children's pain so interesting but also challenging for me is when you're studying children, you're always studying them in the context of their caregivers and their family. Young children also experience communication challenges, and because pain is a subjective event, it can be difficult to truly understand someone else's pain even when they have full communicative abilities. So trying to find out how much pain a child has in the context of research can be challenging. Also, childhood represents a period of very rapid development. So in many ways, those of us doing developmental work, it's like studying a moving target. And it's largely along these three themes that my research program over the last 20 years has developed. This is one of my favorite slides and as an intro to my work on families and pain, because although it's the baby receiving the needle in this picture, it's the father who's feeling the child's pain. And this very much sums up what I'm interested in our research looking at parent responses and how parent behavior impacts child pain. We know from 20 plus years of research that there are certain things that parents do that are related to increases and decreases in child pain. We know that when parents use non-procedural talk or distraction, humor, and give coping prompts like count to 10, that these types of things work to reduce children's pain. We also know that there's a cluster of behaviors that parents engage in that are related to increases in child pain. And criticism isn't that surprising, why that would be related to increases in child pain. But the other behaviors there, apologies, empathy, giving control, reassurance, are a bit counterintuitive. I'll tell you that reassurance is the #1 thing that parents do when their children have pain, yet it has been consistently linked with increases in child pain. I'll tell you more about why in a few minutes. One approach that researchers use, obviously, is studying children who are experiencing pain in a clinical setting or have chronic pain, and we certainly do that in my lab. Although one approach that I use is to bring healthy children in from the community and have them take part in something called the cold presser task. Now, this task involves children lowering their hands into cool, 10-degree water. It does induce clinically significant levels of pain. Children can remove their hand from the water at any time, and any discomfort dissipates rather rapidly after they remove their hand. But what this allows us to do is to study pain in the lab in a controlled way where we can manipulate certain variables related to parents or children's experiences to study the direct impact on pain. This is my research lab at the IWK Health Center, which is just down the street from Dalhousie University. And we have anywhere between 500 and 1,000 children participate in our studies every year. How do you measure pain in children? Well, we do a lot of facial coding, and again, Ken Craig was one of the pioneers in research using facial expression as a measure of pain. We also get self-reports of pain from children using developmentally appropriate measures. So to bring you back to this slide about the relationship between parent behavior and child pain, the problem with this prior work is that it was all correlational in that there are observational studies. It could just be that if you have a child who tends to get upset, you're going to be more likely to reassure them at a medical procedure. So in a study that I conducted here with Ken Craig for my dissertation, we provided the first experimental manipulation of parent behavior during child pain to study the direct effects of maternal behavior on children's pain. In this study, we had children come into the lab. These are 8 to 12-year-olds with their mother. We randomly assigned mothers to engage in one of 3 ways with their children. One group of mothers were trained to be pain promoters. They were instructed to do all the things that research had suggested would be related to increases in child pain. We also had a group of pain reducers, we called them, who were trained to say the distracting, humor-like things that had been found to be related to decreases in child pain. And then we had a control group of mothers that we gave no instruction to. So I'm going to briefly show you some clips to give you an idea of what this looked like. This is a child whose mother is in the pain-reducing condition. And pay attention to what the mother is saying and how it seems to impact the child.
Relax. Okay. Why don't you take a look at the poster? Sometimes it's better to just try and focus away from what's going on. Okay. How many circles are in that poster? 1, 2, let's see that.
4.
Okay. Okay, and how many leaves are on that flower? 1. Big sunflower.
All right, so you see the mother is taking the child's attention away, and it seems to have an effect. The child does not seem to be experiencing as much pain as in the beginning. Contrast that now to a mother of a child in the pain-promoting condition.
Oh, come on, it's not that bad. Oh, it's cold. Just think, your brother probably could keep in a little bit longer. Paralyzed. You're not paralyzed. It hurts. Don't worry, just a little bit longer, but whenever you want to take it out, it's up to you. You're doing fine. It will be over soon. No, it hurts. I want to take it out now. Well, you can take out your hand whenever you want. Now.
So you see the difference in the interaction there. And for the record, we did not tell the mother to say your brother could probably leave it in longer. However, that was brilliant on her part, because that is exactly the kind of mild criticism that parents frequently engage in moments of stress or frustration with their children when they are in pain. So what did we find? Well, there's a reason I'm only showing you videos of girls. Because we found the hypothesized effect in that mothers who were in the pain-promoting condition had daughters who reported significantly more pain, followed by daughters of mothers in the control group, and then followed by the pain-reducing group. But we did not find the effect for boys. So we wondered a lot about why that might be. It's possible that, if we'd had fathers participate in the study, we might have found different results, and we have done a series of studies looking at the role of fathers. We also wondered, there's well-documented sex differences in children's pain responses, that perhaps by age 8, as the kids were in our study, the boys' pain responses were already well socialized, and there wasn't as much room or opportunity for this subtle maternal manipulation to make an effect. When we looked at the kinds of things the mothers said in the pain-promoting group, I mean, we had trained them to say all kinds of stuff, but by their own choice, the most common thing they said were reassuring statements. And so we were left with the question of why? Why is it that maternal and parental reassurance is linked to increases in pain? And this quote from a children's novel, I think may summarize what's going on. And it says, if an adult tells you not to worry, and you weren't worried before, you better hurry up and start, because you're already running late. So this quote signifies perhaps the signaling mechanism that parental emotion and parental reassurance might serve to the child that there's something to be concerned about. And so it's very much along that theme that Megan McMurtry, one of my PhD students, conducted her dissertation work in Halifax. Her paper was titled, "When Don't Worry Communicates Fear." And what she did for her study was a really cool design where she filmed children who were experiencing blood work in our venipuncture lab at the hospital. And while they were filming them, the video was streamed up to our lab, and we identified instances live of the mother or the father reassuring or distracting. After the child's procedure, we had the child come up to our lab, and we sat them down and showed them the video clips of what their parent had been saying when they were having their procedure. And we obtained the children's ratings of how they felt their parent was feeling when they were saying these types of things. We also created a series of video clips with a mock parent, a pretend parent. And we manipulated different aspects of reassurance that we thought might contribute to some of the findings. So for example, it could be that what drives the reassuring effect on children is perhaps the content of the reassuring statement, so whether it's giving any kind of informational value. It could be that it's the facial expression that the parent shows while they're reassuring. Or it could be the linguistic tone. We collaborated with a linguist who showed us a whole body of literature about how when verbalizations are spoken with a rising tone, people pick up on that as reflecting uncertainty, and it can cause anxiety. So to give you an idea of what the child saw, this is a clip of a parent reassuring an actual parent clip. So again, the child would see this and rate the emotions of their parent.
You'll be fine, sweetheart.
So the next clip is just a sample of one of the 12 video vignettes we had created. So this one shows uninformative content, a fearful face, and rising tone.
It's okay. You'll be okay.
So again, the children would rate the emotional experience of the person or the parent in the video. So what did we find? Well, we found, comparing reassurance to distraction, across the board, children consistently rated their parents as much more fearful and less happy when they were reassuring versus distracting. For the video vignettes, we found some interesting interactions and main effects. For uninformative reassurance, so something like, it's okay, you'll be okay, we found a significant effect for facial expression. So when this type of statement was said with a fearful facial expression, you could see the size of the effect there. Children rated the parent as much more fearful than when they said it with a happy facial expression. For informative reassurance, we found an interaction between facial expression and linguistic tone or vocal tone. So such that when parents said informatively reassuring statements with a fearful facial expression and a rising tone, again reflective of uncertainty, children were especially likely to rate these clips and the parent as much more fearful. So from this work, we concluded that indeed children do perceive their parents as fearful when they're reassuring, and we're currently conducting some more studies to more directly look at the role that that appraisal may play in influencing children's pain. Another area where we have conducted research recently is the role of children's memories on their memories for pain on their painful experiences. This is a dissertation by a student of mine, Melanie Knoll, and she was very much interested, at least clinically, what do children remember from procedures and painful events, and how can that, how might that impact them down the road? So in this study, again, she had a sample of 8 to 12-year-olds come into our lab and take part in the cold presser test. We obtained their pain ratings, so we knew how much pain they'd experienced at time 1. 2 weeks later, we contacted them and conducted a validated memory interview, and so we got their ratings of how much pain they remembered experiencing. Now, this part of the study had been done before. Ken and I had published a paper looking at children's accuracy for pain, and in general, kids are quite accurate in their recall, although there is a group of children, anxious children, who do tend to remember painful events as much more painful after the fact than they actually were in the moment. But what Melanie did to extend this work was she had children come back. No one had looked at the impact of what children remembered on their subsequent painful experience. So kids came and did the cold presser task again. And what we found, which is explained in this regression bar graph, was that pain memories, so what children remembered their pain to be, were a far better predictor of subsequent pain at time 2 than their initial pain ratings had been. So just think about that. It wasn't their pain at the initial moment that was related to their subsequent pain. It was what they remembered it to be. Melanie applied some interesting mediational analyses and found that indeed pain memories fully mediated the relationship between initial and subsequent pain reporting. So in other words, it was children's pain memories that were the mechanism through which their pain was related from time 1 to time 2. So all of this research in the lab has led us to look at the types of interventions that psychologists use, whether they involve memory reframing or other types of strategies to help kids during procedures. For the last 10 years, my lab has taken the lead in summarizing psychological evidence in support of procedure pain management, and I was also asked to join the Helping Kids group, which is led by Anna Taddeo at the University of Toronto, and her focus is to address the problem of poorly managed vaccine pain in children. And through my work with Anna, we've conducted a series of systematic reviews, have distilled those into a clinical practice guideline that is published in the Canadian Medical Association Journal. And this table shows some of the interventions that we've identified are effective in managing a vaccination pain. Unfortunately, sometimes people think, what's the big deal? It's just a needle. In addition to all the long-term effects that I went over earlier, we know that many children go on to experience needle phobias as a result of poorly managed pain early in life. And individuals with needle phobias will avoid interacting with the healthcare system at all costs. And there is some evidence that individuals with needle phobias even die younger than those who do not, simply because of their fear of interacting with doctors and not wanting to get a needle. So this is a significant health issue that's not discussed very often. In spite of all this research evidence showing the efficacy of interventions for vaccine pain, fewer than 5% of children, based on our audits, ever get any kind of pain-relieving intervention for vaccine pain. Why is this a problem? Well, part of the problem is that we do a terrible job educating health professionals about pain. This is a headline from a paper that vets better trained for pain than docs. Indeed, they receive more than 5 times the training in pain than physicians do during their medical training. And I've been involved in a number of initiatives to improve education efforts within our own institution, as well as to be engaged in some really interesting but involved knowledge translation activities to try to improve healthcare provider behavior as it relates to pain. I had the good fortune of taking part in a fellowship program 2 years ago called the Mayday Pain and Society program, and the program is dedicated to training pain scientists and clinicians in advocacy and media skills. So I went to Washington, D.C. for a week and received very intensive one-on-one training with a communications firm. And as part of that fellowship, I was assigned a communications coach and had to develop a platform for advocacy work related to pain. And the platform that I developed was that I wanted to reach parents directly about children's pain. Why? Well, it's been my experiences as a parent, and these are my 4 kids here, circa about 3 years ago, who have really had a huge impact on my experience seeing pain management and thinking about it differently. Because through their various surgeries, emergency department visits, hospitalizations, there have been times where even I, a pain management expert, and my husband, who's here tonight, who happens to be an anesthesiologist, that we've had a hard time making sure our kids get good quality, evidence-based pain care. And that's terrifying, because if we can't get good quality pain care for our children, where does that leave every other child whose parent assumes that everything possible is already being done for their children's pain? So with the support of my coach and the Mayday program, we were able to get some pretty high-profile media coverage, a cover story on Parents Canada, a wonderful piece that was published in Maclean's magazine that says, "This won't hurt a bit. We're a leader in pain research, so why are their children suffering?" I've also, over the last year, developed a real strong interest in harnessing the power of social media, Facebook, Twitter, YouTube. These, social media platforms are growing in popularity and influence to the point now where they are one of the #1 sources that parents go to for information about their children's health. And parents rate comments and likes and shares of information as just as credible as the information they get from their doctors. But when you look online, the quality of evidence-based information that parents are accessing are questionable at best. So as part of my fellowship, we decided to create a video for parents, a fun 2-minute, 19-second video, which is hard for an academic to do anything in 2 minutes, and summarize 20 minutes of research in a way that would make it accessible to parents. And I'll show you the video just briefly now.
How is everyone today? You're gonna get some needles today, young lady.
Yeah, we are. Thanks.
My You can distract me with some fun games and get me to take a few deep breaths and play my salads. You can even put a special cream on my own so the needle won't hurt so much. This could all be a lot easier. Do use topical headaches to help. Do the swing me games or the sing a song. Do the chord me to take some deep breaths and play with my lullaby. Don't tell me it's gonna be okay. Don't tell me it'll be all the same. That can make me feel worse. It's better to take my mind off. Mommy, what do you tell me? Come here, Bubba, please.
This has been really helpful for me. Please share this with your friends.
Remember, distract, take deep breaths, use topical anesthetics, and don't say, "It'll be okay," or "It'll be over soon." To learn more, visit our website.
So that was the video, and to our delight, we had an extremely positive response. In the first 2 weeks, it was reviewed over 26,000 times, and via our social media that we'd set up, we had tons of positive comments from parents about the impact of the video. It also generated some media exposure. And this summer, we had a medical student summarize the reach and impact. It's been viewed in over 100 countries to date, and the number of views continues to climb. We were also thrilled we had parents fill out a survey and health providers as well, and we noticed huge increases in the number of parents considering using some of the interventions that were highlighted in the video. We also developed and reached out to people over Twitter, and that has been a very powerful tool to reach reporters like Andre Picard at the Globe and Mail, who's the health reporter, as well as online parenting forums. And we were able to have our video featured in blog posts on parenting sites such as the Yummy Mummy Club. And in fact, the grant that I'm working on right now is with Erica M., who's the former video jockey from Much Music in the 80s, who created the Yummy Mummy Club. And together we're putting in a partnership grant to reach parents with evidence-based information about children's pain. And we're hoping that this science media partnership might serve as a powerful model for other knowledge mobilization initiatives in health research. So to sum up, this is where I'm based in Halifax at the Center for Pediatric Pain Research. If you're interested in learning more about what we do, although we've made a lot of progress, we still have many, many challenges when it comes to helping children with pain. I focused primarily tonight on procedure or acute pain, but obviously the experience of children with chronic pain is one that we need to also continue to address. As I mentioned before, children experience a lot of chronic pain and are significantly disabled by that pain. So although we've come a long way, there's still a lot more work that we need to do. And with that, I'll turn it over to my colleague, Dr. Sullivan. Right, that's a great question, and certainly, yeah, I mean, that I'm having to deal with that limitation in writing my grant right now about clearly when you're doing a partnership with the Yummy Mummy Club, you're excluding an important part of the parent demographic. And I didn't include tonight some of the research that we've done on fathers. Is that causing Yeah, back up. Okay. Sorry, I can hear a little bit of reverb there. One of the things that we've learned is that fathers do play, not surprisingly, a very important and unique role in their children's pain. We've learned that fathers actually are better when it comes to pain assessing than mothers. Mothers significantly underestimate, whereas fathers are more accurate. Fathers do play an important role. We're not sure what the best ways to access fathers are, the way that we're able to access mothers online. Mothers, as you said, are actually the most engaged social media demographic across Canada. Mothers who are online are checking into social media forums, 86% of them once a day. So there's a huge opportunity here. People aren't just using the internet anymore, it's social media and that kind of interaction. And if we don't provide good quality evidence-based information, they're going to find, poor quality evidence. So, yeah.
So I think we'll turn the podium over to Mecca. And Judy, you get first question.
All right. And like Christine, I'd like to thank our hosts for what has been a very engaging and very, very pleasant time so far. So Christine talked about how pain can be a significant cause of disability. And we often have a tendency in this field to almost think of pain and disability as synonymous, so that if you have pain, then you're going to have disability, and if you're going to try to reduce someone's disability, you're going to have to get rid of their pain. And what I'm going to share with you today is some research where we decided to challenge that assumption. And what we essentially did is that we moved forward with developing a treatment program where we were going to try to reduce the disability associated with pain without changing people's pain. So that's the story I'm going to be sharing with you today. This is a graph that shows the magnitude of the pain disability problem in industrialized societies. And these are data from the UK. We have a very similar pattern of data here in North America, but the UK has been collecting data since 1950, so it makes a nicer graph. And essentially what we see is that the pain disability problem has increased dramatically over time. And these are population-adjusted statistics. And we're not looking at the number of people who have pain here. We're looking at the number of working days that are lost due to pain. And in spite of relatively stable prevalence of pain problems, what we've seen is that the disability associated with pain has continued to grow. And when we look inside these statistics, what we're seeing is that today, compared to, let's say, 20 years ago or 30 years ago, when someone goes off work, they're going to be off work for a much longer period of time than was the case previously. And this has happened in spite of every single medical resource that we've thrown at this problem. As a matter of fact, there's recent data that suggests that the more you try to treat someone with a persistent pain problem, the more disabled you're going to make them. And so we're in a situation today where musculoskeletal conditions are considered the most expensive non-malignant health problem that's affecting the working age population. So this is a big problem. One of the things that we've learned over time as well is that interventions that are designed to reduce the severity of pain are not sufficient to get someone who's off work to go back to work. And there's actually some data to suggest that certain types of medication actually are more likely to increase disability than decrease it. And the use of opioids for musculoskeletal pain is a case example. We're putting someone on opioids within 4 weeks of the onset of their musculoskeletal condition, more than triples the duration of work loss that you're going to see in that individual. Now, over the last 30 years, we've seen research pointing increasingly to psychological factors that contribute to disability that's associated with pain. And some of the risk factors or psychosocial risk factors that have been identified are catastrophic thinking, beliefs or expectancies, pain-related fears, and perceptions of injustice. So what are these risk factors? Oops, I went too fast there. So this illustration captures the essence of catastrophic thinking. Here we're talking about individuals who have a tendency to be very alarmist about their pain symptoms. They focus excessively on their pain symptoms, they have a tendency to exaggerate the threat value that's associated with pain, and they feel that there's nothing that can be done to alleviate their suffering. Pain-related fear is another psychological factor that's been linked to disability associated with pain. And you might be asking yourself what this picture has got to do with fear of pain. This is actually an illustration of a treatment scene in a mental institution in the early 1800s. And what we see here is this individual who would be like a precursor to psychiatry, I guess. And what he has in his hands are metal rods that have been heated in these hot coals. And with these metal rods, he's going to burn the faces of these young women. And before the mental health profession was involved in the alleviation of pain, our ancestors actually used pain as a treatment technique for individuals who had severe mental health problems. The belief was that this was an effective way of controlling individuals that had severe mental health problems. So if you put yourself in the shoes of these young women, you'll probably find that your attention is completely fixated on the pain stimulus. The fear that you experience is going to be sufficiently intense as to immobilize you, and whatever you did that made this individual think that you needed this treatment is a behavior that you're less likely to reproduce in the future. Now, if you take that psychology and now put it in the person who's just sustained a musculoskeletal injury, the high fear person is going to have his attention completely fixated on his pain. The fear that he experiences that he has something really seriously wrong is going to be sufficiently intense as to immobilize him, and any activity that he engages in that increases his pain is an activity that he's less likely to engage in the future. And that's how fear can become a driver of disability. Disability beliefs. We have a system that trains people to believe that they are disabled once they have pain. For those of you who work in the area of rehab, you've probably had situations where you had a client that was moving along quite well in their rehabilitation and recovery until someone says to them, "Mr. Smith, I don't think you'll ever be able to go back to work." And at that point, the belief that emerges in our client's mind is that I am totally and permanently disabled. And the thing about beliefs is that they're the road maps to human behavior, is that you behave in ways that are consistent with your beliefs. And once this belief is instilled, Jack is going to behave as if he is permanently and totally disabled, regardless of his underlying symptom levels. And over the last few years, we've seen more and more research suggesting that individuals who experience their loss or their suffering associated with pain in terms of justice-related themes are going to be disabled for a much longer period of time than individuals who don't entertain justice-related themes in reflecting on their experience. And research suggests that these psychosocial risk factors can account for as much as 30% of the variance in the magnitude of disability associated with pain, and that's a lot of variance. So if you have some variables that are accounting for this much of the magnitude of the disability problem, it makes sense to try to develop interventions that target these psychosocial factors, and that's what we've tried to do. So over the last 20 years, almost, I guess, we've been working, we've been using an intervention program that we refer to as the Progressive Goal Attainment Program as a platform to essentially test out ideas about the effectiveness, the feasibility, the utility of targeting certain psychosocial risk factors to reduce disability in individuals that have persistent pain conditions. And to understand what PGAP is all about, in your mind, first of all, you have to separate symptoms and disability and consider them to be completely separate and distinct targets of your intervention. And as I mentioned in the past, we had the assumption that disability was caused or fully accounted for by symptoms, and if you could get rid of the symptoms, then the disability would disappear. But research has really invited us to reconsider that assumption because the relationship between symptom severity and disability is not all that strong. And what we thought, so maybe it would make sense, rather than focusing all of our attention on treating symptoms, is to have an intervention that was designed specifically to target disability and not symptoms. Now, when I say that, people go, "Oh my God, you're not going to treat the pain of these individuals?" I'm not saying that. To the degree that we have interventions that can reduce the severity of someone's symptoms, then yes, we have to use those. But we also have to understand the limits of those intervention tools. In the area of pain, whatever you use, whether it's going to be a pharmacological, a surgical, or if it's going to be a psychological intervention, if it's going to work, it's going to work within 8 weeks. And if it hasn't worked within 8 weeks, it's not going to be working. And so one of the things that happens right now in this area is that we get stuck here. We just treat the symptoms indefinitely. And in so doing, not only are we exposing the person to ineffective treatments, but those multiple failures of treatment are probably going to be contributing to increasing the person's level of disability. So what we suggest is use your symptom-focused tools at the beginning, but as soon as you can, you want to be shifting as well to start targeting the disability that's associated with pain. And you want to try to do this as soon as possible before the disability becomes a lifestyle. Because that's what happens to disability, is that the longer that someone is disabled, the more that the disability transforms itself from being a clinical problem to being a lifestyle problem. And once it's a lifestyle problem, essentially we're disabled as interventionists because we don't have a whole lot of tools to change lifestyles. So PGAP it's a standardized intervention where we invite rehabilitation professionals like physical therapists, occupational therapists, psychologists, to follow a 2-day training program where we equip them with the skills of the intervention program. There's a client workbook that's used as a platform to deliver the intervention techniques. And then there's a video that we use to both educate the client about disability associated with pain and also to introduce the client to the intervention program. I'm just going to show you a couple of clips from the video. So one of the things that we know in this area is that you need to be educating your client about the condition that they have. And one of the things that we've done in our video is that we don't educate them about pain because we're not going to treat pain in our program. We educate them about disability and how to prevent disability. So we have a narrator that's describing the problem of pain and disability, and at one point she basically starts focusing on issues related to the negative consequences of inactivity. Because in this intervention we're going to be trying to take someone who's disabled, essentially someone who is disengaged from many domains of activity in their lives, and try to re-engage them as much as possible into those activity domains that have been discontinued.
In the past, we've tried to treat pain conditions by getting people to rest and remain inactive. We told them to stop working, to rest, and to avoid activities that made the pain worse. But it soon became clear that activity reduction was not the best way to proceed in treating pain conditions. We now know that reducing activity might be the worst thing to do in the treatment of a pain condition.
What's next here?
Pain conditions have the best chance of recovery if we remain as active as we possibly can.
So if you have a master volume somewhere, that would be great. Because it is going through here.
It is going through here, and I think we can probably tweak it here, but Alan would know.
This one here?
That'll bring your voice up too, though.
It'll bring my voice up too? All right. Wow. So the narrator talks about the importance of resuming activity as a key to maximizing your rehabilitation success. And then in the video, we have that message supplemented by the voices of physicians as well, because we know that patients consider those voices to be highly credible voices.
The modern approach to soft tissue injuries is one that emphasizes early return to the workplace, much like with athletics. We would never put somebody on the sidelines for an extended period of time because they decondition so badly that you just never get them back to that environment, whether it's skating or whether it's working on the assembly line. So the current approach is to take the tissue that is hurt, modify the activity, but keep the tissue keep the tissue challenged, because that's how it heals best. And we've studied that and we know that, and Hippocrates emphasized that.
So you have one physician that's talking about how even at the tissue level you need to challenge tissues in order to kick in repair mechanisms.
The physician has to always ask the question, what exactly is it about being at home that will cure this condition?
And so another physician talks about the fact that there is no curative process that occurs at home.
Most employers these days are quite
anxious to take people back to work and get them involved in that work milieu so that they will soon be able to go back to the type of work they did before. So again, it's when you're up and you're active, you do not have to be pain-free to go back to work.
And the last message here is really important about you don't have to be pain-free to go back to work, because research is telling us that about 60% of people who sustain musculoskeletal injuries are going to be experiencing symptoms to some degree for a very, very long period, perhaps the rest of their lives. And one of the things that happens in the video as well is that we mentioned that return to work is the objective of this treatment. So the client's watching this video and the narrator says, and the goal of PGAP is to help you get back to work. And we need to do this because research tells us that you're going to attain your treatment objectives a lot more successfully if the client's aware of what those are. So if you don't tell your client what the treatment objective is, there's going to be a lower probability of success. Now, often in the area of pain, we don't like mentioning return to work so soon to our client because we think that it's going to damage the working relationship that we're trying to build with our client. The client might think that we're working for the insurance company more than we care about their needs. And we recognize that, and so in trying to balance the idea of saying, well, you have to make your treatment objective clear, but you don't want to damage their working relationship, is that in PGAP, the clinician doesn't have to say that this is a program about getting you back to work. It's the narrator in the video that says it. And so the message is delivered, but not by the clinician. And we also have the narrator say, but if you can't go back to work, participating in this program can still be helpful in increasing your quality of life. So for clients who watch the video and say, but this program's not for me because I can't go back to work, is that the clinician then says yes, but the narrator also said that this is about increasing your quality of life, and that's where we're going to start. So if you're the client in this intervention program, we're going to be providing you with a client workbook, and part of the client workbook is set up very much like a daily agenda. In the first week of the intervention program, we're just going to ask you to write down all the things that you do during the course of the day. So you can say, it's going to be really important for me to understand how your pain has affected your life. For the next week, I'd like you to take some time and just each day jot down the activities that you do during the course of the day. And this kind of becomes our baseline. And for a lot of the clients that are work disabled with pain conditions, what we see is that they've moved towards a very sedentary type of lifestyle where you see a bit of a flurry of activity around mealtime, but that the rest of the day is really characterized by a whole lot of sedentary types of activities. And whether you're looking at this activity profile with a psychological lens or a physical lens or a medical lens, this is bad news. The longer that this person does this, the more difficult the future is going to be for that individual. In the second week of the program and then onward, the format of the client workbook changes so that now we're not just going to be logging activities, we're going to be planning activities. And the first thing that we're going to be getting our client to do is we're going to be getting our client to get up at the same time that he or she was getting up at when he or she was working, to go through the same morning routine at the time that he or she would have left to go to work. We're going to get the person to take a 15-minute walk. What we're doing here, as of the second week of the intervention program, we're trying to reinstate the activity structure that existed when the client was working. We're going to be slowly trying to get our client to start behaving like an individual who's working. And what we're trying to do here is that we're trying to get the client to behave in ways that are incompatible with the client's disability beliefs. So we want to change the client's disability beliefs, but we know we're not going to be able to talk the person out of their beliefs because human beings don't like changing their beliefs. And if they perceive that you're trying to talk them out of their beliefs, they actually react defensively to that. So what we're going to do is rather than talk our clients out of their disability beliefs, we're going to have them behave their way out of their disability beliefs. In the second week, we're just going to ask the client to think of one new activity that we could be incorporating into our plan. And here the client suggests that his wife has been bothering him to clean the garage for a while. Maybe he could do that. And so we're going to ask the client, how long could you do that before you would pay the price for it the next day? Essentially, we're asking the client to give us a sense of what his activity tolerance is for that type of activity. If the client says, I could probably do it for about 30 minutes, we're going to say, okay, well, I want you to do it for 15 minutes. So we're going to pick a duration of time that we know is going to be below the client's tolerance limits, but we're going to then schedule that activity repeatedly. And one of the things that we know is that repeated exposure is one of the best techniques to reduce someone's fear. And if fear is driving part of my client's disability, if fear is the reason that my client is not participating in activity, then exposing my client repeatedly to those activity domains within the client's tolerance limits is going to be a useful tool for reducing my client's level of fear of pain. One of the things that we know about fear as well, it's a driver of pain, or it augments pain. So if I can reduce the fear, I also know that that's going to be to some degree alleviating the severity of my client's symptoms, allowing my client to progressively engage in more and more of that activity. So the intervention program here is one that's going to be delivered by our PGAP provider, who's going to meet with our client once a week for about an hour to a maximum of 10 weeks. And at the beginning of the intervention program, we get a sense of what our client's disability profile is like at this point. We then introduce an activity structure that we continue to populate with goal-directed activities until we reach a point where the client is engaging in activity to a sufficient degree that we can now feasibly consider a transition back to the workplace. And where I mentioned that it's a maximum of 10 weeks is that the goal of PGAP is to help someone return to work. So as soon as the person is ready to transition back to the workplace, is that the program ends. So the goal is not to keep the client in treatment for 10 weeks, is that clients will differ in terms of their rate of recovery or their rate of progress, and some who are recovering or basically progressing very well might be transitioning back to the workplace at week 5. For those who are making a slower rate of improvement, is that we'll continue to work with them till about 10 weeks, but we'll never go beyond 10 weeks because the research that we've conducted suggests that if these tools work, they work within 10 weeks, and if they don't work in 10 weeks, they don't work in 20 or 30 weeks either. And what we do is that we also assess our psychosocial risk factors at the beginning, in the middle, and at the end of the intervention program. We're hoping that the tools that we're using are going to bring those psychosocial risk factors down. And our research suggests that the more that we can reduce these psychosocial risk factors, the greater the probability of transitioning someone back to the workplace. And the research suggests that reductions in catastrophic thinking are going to be the critical element, in the sense that the more that you can reduce catastrophic thinking, the greater the probability of return to work. So what we've tried to do here, which is a bit different than other types of psychological approaches that have been used in the management of pain and disability, is that rather than in a traditional cognitive behavioral sense where we try to change the way a person thinks to affect how they behave, what we're going to be trying to do in PGAP is actually try to change their behavior as a means of changing how they think. And it's not that different than, let's say, for those of you who are parents and at some point you decide that you're going to enroll your kids in soccer because you think that soccer is going to be good to teach them about responsibility and discipline and perseverance. Well, those are all psychosocial objectives, even though the soccer coach would not be thinking of himself as a psychosocial interventionist. But activity is not the only technique that we're going to be using here. We're going to be using other techniques that are designed specifically to target these different psychosocial risk factors. So we're going to be using validation techniques to target perceived injustice, guided disclosure to reduce catastrophic thinking, repeated exposure to discontinued activities to reduce fear, and getting our client to behave in a way that's incompatible with their disability beliefs. So, does it make a difference, this kind of intervention? Our research suggests, yes, it can make a difference. This is a paper where we describe the effectiveness of PGAP for individuals who have recently become work disabled. So this is a workers' compensation board claimant cohort that they would all be between about 4 to 8 weeks post-injury when they were enrolled in the trial. And what we did in this trial is that we compared PGAP to traditional care, which would be physical therapy. So the two groups here were individuals who participated in the physical therapy program, a functional restoration kind of program, and then clients who participated in the same physio program with PGAP, and we asked ourselves the question, does adding PGAP make a difference to return to work outcomes here? And in this group, where you'd be expecting fairly high return to work rates because you're catching people on a natural course of recovery, in the physio group, when we evaluated return to work 1 year after the treatment, approximately 70% of the individuals in the physio group had returned to work, and we saw a 40% increase in the probability of return to work in the arm that received PGAP. So just receiving an additional hour a week of an intervention increased by 40% the probability of return to work. We also conducted a trial looking at PGAP in the context of individuals who had sustained whiplash injuries, and again using the same type of design here where we compare physio to physio and PGAP. And what we did here is that we also looked at, we broke the sample down into subsamples where, as a function of the number of psychosocial risk factors that the individual had elevations on when they first came into the program. And so on the left-hand side there under 1, that means the person had an elevation on one psychosocial risk factor, and 4 means that they had elevations on all 4 psychosocial risk factors. And when we see the return to work advantage for PGAP, the red bars, when there's 1 or 2 psychosocial risk factors, is significant, but not a whopping difference. But when we start looking at individuals that had elevations on all 4 psychosocial risk factors, participation in PGAP more than doubles the probability of return to work. So the added value of PGAP seems to become more pronounced as the number of risk factors increases. And then at one point, we were approached by the Social Security Administration in the US asking us whether it might be possible to develop a telephonic version of PGAP, because they were interested in using the PGAP model to try to target disability in their disability insurance population. And the Social Security Administration in the US is similar to our Canada pension. So if you develop a health condition that becomes sufficiently severe that you're no longer able to work anymore, that you would apply for Canada pension for some kind of financial subsidy. And that's what the SSA does. Their situation is that they have 160,000 new claimants come on to disability insurance every year. No one goes off without dying. And from their perspective, saying, we just can't keep going like this, it's going to break the bank eventually. And their thoughts are, the way we've come to understand disability is that the health conditions underlying disability can wax and wane in their severity through a person's lifetime, so that even though the condition was sufficiently severe to warrant going on disability at one point, does not necessarily mean that you're going to be that disabled for the rest of your life. And so they were wondering whether something telephonically could be done to work with these individuals. And when in our first discussions I was saying, I was like, well, really, I was like, if your people are like our Canada pension people, I was like, PGAP works well for people who have just gotten off work. But we have no idea whether it's going to work for individuals that have been off work for years and that have very severe and often comorbid types of conditions. So I was saying, so don't expect that we're going to be clocking the same kind of return to work outcomes that we've seen in our workers' comp or in our whiplash studies. And one of the numbers people at the SSA said, it goes, well, assuming that we roll out this kind of intervention, and telephonically it's easy to roll out because you don't have to have clinicians everywhere in the country. You just essentially just need a PGAP call center, and then from there you can reach anybody that owns a telephone. And they said, assuming that we roll this out to the entire country, you get 1% of these people back to work. We save $3 billion a year. And so from a population health perspective, you don't need to be clocking the same type of outcomes that you do in one study before it has a very, very meaningful effect. So we ran the study with them, and so a call center was set up where we trained these individuals to be our PGAP callers, and from there 2,000 people were randomly assigned to one of 3 arms of a trial. There was a control group. There was one group that received medical insurance because all these people were uninsured, so they had no access to health care. And then a third group had the health care plus PGAP. And the PGAP arm of the trial showed a return to work advantage that basically persisted for even into 2 years follow-up, which is really a long time to do follow-up in these kinds of studies. And I think it's probably one of the largest rehabilitation trials that was ever conducted. It cost $40 million to run that trial. And you might be asking yourself, how does it cost $40 million? How expensive is a phone call? Well, what happens is that because in the US, you can't do anything that's going to compete with private enterprise, as soon as we were going to have an arm of the trial where people were going to receive medical care, we couldn't just give them medical care. we had to purchase medical insurance for everybody in the trial. And medical insurance in the States is about $15,000 per year. So $15,000 per year times 2 years times 2,000 people, and you get into the $40 million. So now, one of the things that's really interesting about this trial is that it actually, the results of this trial led to a change in policy at the SSA, where previously, very much like Canada Pension, their mandate was completely just a living subsidy mandate, so that you get sick, you can't work, is that you're going to get enough money from them to live on. And as a function of the trial, because they were able to demonstrate that, yes, with some type of intervention, a lot of these people can return to work, is that they've now changed their mandate to be a rehabilitation mandate. So that now when you go on SSA, it's not that you just go on and they leave you there, is that you go on and they're going to make accessible to you resources that could potentially increase your ability to eventually get back to work. So the lessons we've learned in this area, I think that certainly we've become convinced that it makes a lot of sense when you're intervening with someone that has a debilitating health or mental health condition, is to separate symptoms and disability as completely different targets of your intervention, because getting rid of symptoms is not necessarily going to get rid of disability, and you're going to need different types of tools, whether you're targeting symptoms or whether you're targeting disability. I think it's also made me believe even stronger that return to work always has to be an objective of treatment when we're working with someone who is work disabled. And I think that we haven't done a lot of that. And as a matter of fact, in our healthcare system, we seem to be more ready to pull someone out of the workplace than we are to try to consider how we might be able to keep the person in the workplace. And the physician who says, oh, I'll take you off work for a couple of weeks, Jack, is not thinking of the challenges that we're now going to face in trying to get Jack back into the workplace. And I'm hoping that at some point we're going to be able to get to a position where the first thought of the physician is not going to be, how can we take you out of the workplace? Because, as one of the physicians said on the video, there's no curative process that occurs at home. But rather than taking Jack out of the workplace, how can we try to accommodate your workplace during this period when your symptoms are very debilitating, but we're going to keep you there, with the idea being that your symptoms are not always going to be this bad. And I think it also highlighted it to us that it was possible to use population health models to deliver a psychological intervention. Whereas the type of health model that governs the delivery of psychological services is essentially referred to as a boutique model, where we offer a very specialized service to very few people. But I think that we were able to demonstrate here that you can use a delivery model in such a way that you can target or make as accessible as possible your psychological intervention, such that theoretically it could potentially reach every person who might be in need of that intervention. And that's the end of my story. Thanks a lot for your attention.
So we've got about 10 minutes for questions. Open the podium for both Christine and Mike. Yes. Oh,
yeah.
Judy had it first. Okay.
You emphasised the importance of distinguishing between symptoms and disability. I was struck that you didn't pick out a distinction between disability and being out of work. Do you agree that it's possible to be both disabled and in work?
Well, again, yes, and I think that from our purposes, we've been focusing on work disability as the primary target. And I mean, there's a variety of reasons for that. One of them being a basic funding issue, in the sense that it's the people who are paying wage indemnity are the ones who are going to be most interested in funding research that is going to be helping someone get back to work. They're not necessarily going to be interested in funding research where someone's going to become less disabled but still out of work. And so that's one of the reasons. The other one is, it probably comes from a philosophical bias that I have, that for someone who is work disabled, is that return to work is the highest level of independence that you can offer that individual. And I believe that all our clients deserve a shot at that. We live in a system right now that makes people believe that they are more disabled perhaps than they need to consider themselves disabled. And so I think we have like all of our clients, when they first come into the program, they don't believe they can go back to work. But I believe they can go back to work. But I also believe that the reason they don't believe is because we made them believe like that, and therefore we have a responsibility to make them believe more in their abilities than in their disabilities. So, yeah. Okay. Yes, sure.
Okay, well, and my question was for Christine, having to do with, because pain is related to the social situation you're in, whether or not there are ethnic differences in perception of pain, and therefore that you employ those in some way when you're dealing with pain in childhood.
Right. So that's a great question. Toss it back and forth. So the question was around ethnic or potentially cultural differences in pain expression. And certainly there have been some studies, both child samples and adults as well, showing different cultural and ethnic expressions of pain. And it's just that, you know, some cultures encourage more expression of emotion or physical symptoms, or more stoicism, where one is taught to inhibit pain expression and communication. So yes, I mean, we do know that those differences are there, and it is very important to kind of understand when working with individual patients what kind of context or environment that they grew up in that either might have, you know, encouraged or discouraged pain displays. It hasn't really been formally integrated into intervention programs per se, but I would say it's one of those things that those of us who work with patients who have pain, you know, consider as part of our assessment, and whether, you know, and I mean, really, when we're working with children who have chronic pain, I mean, the goals are very much the same, except school is kids' work, and often our challenge is getting kids back to school. And often there's a dynamic in a family where, you know, again, it's when does an acute problem become a chronic problem, and your approach has to shift. It's that thinking differently about your own problem. Parents sometimes give too much attention to pain in their children. It can become the only thing that parents and children talk about when their children have pain. And so it, you know, and maybe that's for cultural reasons or for whatever might be driving that. So shifting the contingencies very much in the way that Mick has described around, you know, emphasizing functioning and, you know, appropriate coping, at the same time validating someone's experience. You don't want to be seen as minimizing that. So, yeah.
Is it something that's been studied in children?
Cultural and ethnic variations, yes, but there's sort of formal integration into treatment, no. Yeah.
There was a question way over there a moment ago, so why don't we proceed with you? Yes.
So, this is you struggling with this concern that you're trying to get people back to work, and someone could defensively perceive that sort of that's this tough love, and that works as like vicious capitalism, just getting people out there. But I don't, it doesn't seem like that's the case, and I can see a lot of the reasons why getting back to work makes a person healthier. Have you ever exit polling at the end, like a year later, when you get people back into work? Are they grateful for the program? Do they recognize the value? Like, can you help build that into the narrative so that people at the front end recognize that they're getting a good deal?
I think the research, I think, overwhelmingly shows that, you know, it's like your life trajectory as a person who's out of work is going to be filled with a lot more hardship and distress than the person who returns to work. And we don't, one of the things, like, yes, we make return to work a central focus of what we're doing, but really what we do in this program is that all the activity reintegration that occurs is in the domain, because we're not at work with the client, is in domestic, family, social, and community activities. That's what we re-engage them in. And we're hoping that through that process, they start to believe that work is now a possible thing as well. But one of the things that we know about this population as well is that some of these people are going to be so debilitated that return to work is not going to happen for them. And we didn't want another intervention that was going to make people feel like they failed again if they didn't go back to work. And by focusing on domestic, family, social, and community activity engagement, what we're hoping is that even the person doesn't go back to work, they're still going to experience their participation in the program as something that has increased their quality of life, so that no one fails. In terms of what happens when you go back to work, that's a difficult one to answer, because in the insurance context within which a lot of these people say that they must navigate through their rehabilitation, I wouldn't say coercion is going to be a force there, but there's a certain pressure for them to move in that direction, otherwise that they are going to face some potential adverse consequences to their claim. And you know, that's good and bad in the sense that you don't want to be pushing someone back towards something that they can't do, but we also know that we have a system that promotes disability so much that if that coercive element wasn't there to some degree, that much fewer people would be going back to work. In terms of, do we have people that have said, you know, this is the most amazing thing? We've also used this program to target disability associated with mental health conditions, so that people who have a primary mental health diagnosis, because essentially the risk factors for disability are the same. And we just finished a trial of PGAP with military vets with PTSD in the US. And we had, at the end of the project, where there was presentations from the researchers and also some accounts given by individuals that had participated in the program. One individual who was speaking and said that he thought that the program had saved his life. So I think that it's you know, I don't want to give the picture that, you know, everybody walks away thinking that this is the best thing that's ever happened to them, but that I think that it's, for a lot of people, I think it's put them in a much better place than they were in prior to participating in the program.
I think I'm going to ask Michael to ask the last question. Sorry. So, things like getting into this work is hopeful. My question is about how much return to work, because would it be fair to assume that someone who has a new problem with may not be able to be engaged in the same capacity, and yet the system and workplaces and businesses are often almost an all or none phenomenon. Just how is that varied, or is that varied?
Right. So you know, I admitted my bias that I believe that, you know, as like our treatment objective should always be return to work, because I believe that it's the best place for the human psyche to be. But it doesn't mean that any kind of work is the work that's the best place for the human psyche to be. And for, let's say, for a lot of people that we worked with who have a primary mental health condition, and a significant proportion of them, the mental health condition is related to the workplace that they were in previously. And so we're taking those individuals and putting them back in the workplace that contributed to their depression is not necessarily the right answer. And so I think that you always have to bring a certain degree of clinical judgment to bear about saying, yes, we're going to do our best to get you re-engaged. We also need to take a look at where's the best place for you. And then after that, what resources and what flexibility do we have to bring you to the best place for you? And insurers and the context of an injury or a debilitating mental health condition is going to play a significant role in what flexibility there is. So for example, workers' comp, there is no flexibility. You just go back to where you were doing before. With LTD insurers, because they know that this person's been disabled for a very long time, and if we don't do something, then the period of disability is going to extend even further, they're much more likely to say, okay, well, what if we were going to reconsider some retraining or redirection for this individual? Do you think that this person will be able to move in that direction? And obviously flexibility is what you want there. And unfortunately, most insurers don't bring a lot of that to bear. So.